Thank you for joining us today. This is our webinar series brought to you by the Eye and Ear Foundation. My name is Lawton Snyder. I'm the CEO of the Eye and Ear Foundation. And this bi-weekly webinar series highlights research at the University of Pittsburgh School of Medicine. We support research through the Eye and Ear Foundation to advance care for vision, hearing, balance, voice, and cancers of the head and neck at two world-renowned departments for both ophthalmology and otolaryngology at the University of Pittsburgh. The funds we provide from the Eye and Ear Foundation to support research are only made possible because of philanthropic support, which is certainly the mission of the Eye and Ear Foundation. So we appreciate that to give you that opportunity to support through the Eye and Ear Foundation any of the things that you learn in our programs from our webinar series. So let me just do a few housekeeping things for our webinar series today. We disable the chat for these programs, but you can use Q&A function, which is the question and answer function at the bottom of your screen. We really want you to ask questions. So please ask questions anytime during the program. We will hold all questions until the end, and I'll read the question to our two panelists for today. We'll ask you to refrain from personal health questions that may not be as interesting to the rest of the audience, and I'll kind of maybe hold some of those that we'll answer online later, but we'll try to get everybody's questions answered regardless. Please feel free to use the subtitle function for closed captioning if you need to at the bottom of your screen as well. And then you'll be added to our email list for future webinars and for programs like this. So we have a great program today, and the title or topic of today's program is Understanding Common Eye Infections. I think you'll find that this is something that's very practical for all of us that we have to deal with upon occasion, and you're certainly talking to the right people if that's ever the case. So today we're going to hear from Dr. Alex Mammen, Clinical Assistant Professor of Ophthalmology, Cornea, Cataract, and External Disease Service, Refractive Surgery Service at the University of Pittsburgh School of Medicine, and Medical Director of the Charles T. Campbell Microbiology Laboratory. And then he will be followed by Regis Kowalski, who is our Research Professor of Ophthalmology, Executive Director of the Charles T. Campbell Ophthalmic Microbiology Laboratory at the University of Pittsburgh School of Medicine. Dr. Mammen, if you would, get us started, and thank you for today's presentation.
All right, thank you, Lonnie. It's a great privilege to be here and to talk a little bit about something we're really passionate about, and that's to treat eye infections and potentially, hopefully, save vision. So these infections can not just be vision threatening, can be globe threatening. We have the unique privilege of having an ophthalmic microbiology laboratory here at the University of Pittsburgh. There aren't too many still around. Nationally, they've been absorbed into the larger laboratories. So it really changes the way that we can practice ophthalmology and really improve patient care to have a specialty laboratory as part of the department. So without further ado, let's get started. So what parts of the eye can get infected? Really any part of the eye, any tissue, fluid, or space within the eye, around the eye. But we're going to focus on a few of the parts of the eye listed here. The first being the eyelids. Second, conjunctiva. That's the skin on the white, overlying the white of the eye, the white being the sclera, and the fluid within the eye. So the aqueous fluid that's in front of the lens of the eye, and the vitreous fluid that's behind the lens of the eye and in front of the retina. So if we look at these pictures here, you can see eyelids, and you have the gland to the top left, that's a lacrimal gland. It produces tears in response to irritation or if you were to cry. There are smaller glands that also make tears on a constant basis that are within the conjunctiva, or that skin that I mentioned. And all these tears drain into the lacrimal system. So that's the sac that you can see on the right side of the first picture. And so these parts can also get infected. The cornea is that clear part of the eye, kind of like the lens in a camera. And the sclera, as I mentioned earlier, was the white. And then behind that cornea, there's a space filled with fluid. And there's the colored part of the eye, the iris, the opening in that is the pupil. And then there's a lens behind that. And then behind that is the vitreous. So just to give you a general overview of what we're going to be talking about. So if we start with the eyelids, very common. We see hordeola or styes. So these are blocked oil glands. So these oils are made by glands within the eyelid. The oil is necessary to keep the tears from evaporating. So between blinks, it's such a thin layer of tears that coats the surface of the eye that in order to keep it from evaporating immediately after a blink, you have oil. So these oil glands are necessary to keep those tears there and to help with vision. So if these oil glands get blocked, you can have essentially like a pimple of the eyelid. There are bacteria that live on our skin, as we all know, staph bacteria, and they also live along the eyelids and the eyelid margins and within these oil glands. So in addition to these glands getting blocked, they can also be associated with a proliferation of these bacteria, most commonly the staph bacteria. So in the first picture there, that's just your usual presentation of a stye, and you can see a little bit of that white material. So some of that is the oil within the oil gland. Some of it is the white blood cells that come in when you have inflammation. You can have some bacteria there as well. So it can get more involved in the surrounding parts of the eyelid, and it can develop into what's called a cellulitis or a skin infection. So there's the spread of that infection, not just where that blocked oil gland is, but to the surrounding tissue. So the treatment for this, heat can help to reduce some of the inflammation and can also bring it to a head. A combination of an antibiotic and steroid ointment can be used to help reduce the inflammation and reduce some of the bacteria. And then if it's cellulitis, as shown in the bottom photo, oral antibiotics can help speed up recovery. So most common eyelid infection and inflammation that we see. So moving on to the conjunctiva, you can also have what's called a Blepharoconjunctivitis. So that's an eyelid infection plus involvement of that skin on the white of the eye or the conjunctiva. So this is an 86-year-old female patient who presented with a 9-month history of intermittent yellow discharge from her eyes. And you can see all this crusting on those eyelashes. So in situations like this, it's useful to have our laboratory readily available so that we can see what is causing this discharge. So when we culture the discharge from the eyelids, and we put it onto plates, we get some growth of staph bacteria. And so on the photo on the left, this is a special stain called Giemsa stain. And you can see these small little bacteria. So they're in they're cocci or little clusters, small round bacteria that cluster into little groups. So staph bacteria. And then you can also see that on the plates, different ways that we can differentiate the species of staph. So in this case, it was Staphylococcus aureus. So we can then use that information and the experience that we've had over the years of treating these bacteria. So the Campbell Laboratory has a list of common bacteria from different cultures that we've done. And this is from 1993 to 2019 in this table that's shown. So if we look at Staph aureus, for example, we can see the susceptibility testing to different antibiotics. And so that can help us tailor the treatment to the organism that we find from our cultures, as well as from our slides and smears. So in this situation, we might use an ointment such as a bacitracin. We might use drops like gentamicin or polytrim, which is polymyxin B trimethoprim. So we have some different options that we can use, but having that culture information is very useful. And then for all that crusting that you saw on the lashes, warm compresses, eyelid wipes can help to remove some of that debris. So this is another case of bacterial conjunctivitis. So in bacterial conjunctivitis, you tend to have more of a pus-like drainage. So you can see the normal eye on the right or left on your image, but the right eye, that's normal. In the left eye, this is a pus-like or purulent discharge. And so again, we get some smear. So we put that on slides and we can stain it. And we can see here, this is bacteria that they group in pairs. So this is a bacteria called Moraxella. So we can again go back to our table here, Moraxella, and then we can use this information. So thankfully, this is fairly susceptible to the majority of the antibiotics that have been tested. So we have many options there for treatment. This patient was treated and did well. So viral conjunctivitis. So in this situation, the discharge is different. Instead of being like the pus-like discharge, you get more of a watery discharge. You have one eye that may start and then it may spread to the other eye. It's very common. Usually in viral conjunctivitis, it's usually the same sorts of viruses that cause the common cold. So we usually don't test for those viruses unless there's a question or an atypical presentation, something that may be concerning if it hasn't gotten better. Within the usual 7 to 10 day period, we may check to see what the virus is. Treatment is usually supportive care, so lubrication, cool compresses, and it gets better on its own. You can also have lymph nodes in front of the ear or preauricular lymph nodes in viral conjunctivitis. So more severe presentations of that, you can have the same virus, but sometimes depending on the strain of the virus, it may manifest with what's called pseudomembranes, as seen in the photo on the left. So significantly more symptomatic, more uncomfortable. So these membranes can be peeled off, but you really need some steroids to calm down the inflammation, the body's response to the virus. In the photo on the right, this is again an immune reaction of the body to the virus. And you can see what's called subepithelial infiltrates in the cornea. And again, steroid drops can be useful and can help reduce not just symptoms, but some of the visual decline that can be seen in this situation. Moving on to the cornea. This is an 80-year-old female contact lens wearer. She presented with a 4-day history of right eye pain and redness. So on the photo, you can see that white circular area. So that's the bacteria as well as the body's response to the bacteria. So it's a corneal ulcer. So the surface layer of the cornea, the epithelium or the skin of the cornea is missing. And the bacteria is actually eaten away at a lot of the tissue within the cornea. And there's necrosis of that. And there's a lot of that white mucus-like material that's a combination of the bacteria, some of the cells, so the white blood cells, as well as some of the tissue from the cornea. So this is a contact lens related corneal ulcer. So we're going to get some smears on the slide. So we take some of that material and we put it on a slide and we stain it. And our microbiology team can help us determine what is the organism that's causing this. And in situations like this, when it's this purulent, again, just like the conjunctivitis, this tends to be purulent and bacterial origin. So these are gram-negative rods. This is Pseudomonas. It's a common bacteria that's associated with contact lens-related infections. So heavy Pseudomonas growth, and again, we have sensitivity or susceptibility testing that's done to different antibiotics. Helps us guide treatment. So aggressive antibiotic eye drop is the treatment that is warranted in this situation. And in a condition like this with the Pseudomonas, that bacteria can really eat away at the cornea very quickly and can result in a perforation of the cornea. So aggressive treatment is warranted. And if you look at the culture plates, it's classic, this greenish appearance on the plate. This is a blood agar plate. And so Reach can even look at it and even smell. It gives off a certain odor, and he can diagnose it. Maybe without even looking at it, he could probably diagnose this as Pseudomonas. So sometimes the Pseudomonas or other corneal ulcers can be very aggressive, and the cornea has a difficult time healing itself. So we may utilize things like amniotic membranes. It's what surrounds babies in utero. These membranes are processed, and we use it for healing of the eye. So this was a patient who had a severe corneal ulcer. So her entire cornea was affected. The surface wasn't healing. We had concerns about the cornea perforating. So we glued on with a special glue that we use on the eye, a fibrin glue made from components of the blood, clotting factors. So we use that to glue this special membrane on, and we also sew on some of the membrane surrounding the cornea, and there's a contact lens which functions like a Band-Aid, and that really helps the eye heal well. We use what's called autologous serum drops, which just means that it's drawn from the patient. So we draw blood, we spin it down, we take the liquid portion, we dilute it to certain concentrations with saline, and then we use that as an eye drop. So that is also excellent for healing of the eye. So in this patient that I showed before, where we used the amniotic membrane, that cornea healed, and once the eye is quiet, then we take the patient to the operating room for a corneal transplant. Because what happens is after the eye is healed, there's a lot of scarring. So what was a clear structure in the cornea has become scarred, and it obscures vision. So these patients need corneal transplants. And so this is a corneal transplant. You can see all these fine sutures, 16 sutures we put around the cornea. That's typical. In this case, get a lot of scarring inside the eye, and that light brown structure you can see, that's her lens. She has a very dense cataract. Part of that is age-related changes, but also when you have a lot of inflammation, you can get progression of that cataract. So she subsequently needed cataract surgery, and she's doing fairly well, considering that she almost lost her eye. So the last infection that I want to touch on is an infection that can occur after a very common surgery, cataract surgery. And so this is one of the things that we take special precautions to try and avoid, because it can significantly compromise vision, and can also be globe threatening. So it can cause loss of the eye if severe enough. So this was a patient who a few days after cataract surgery started noticing increased redness, decreasing vision. And you can see here all the cornea is hazy in appearance. There's a lot of material, inflammatory material, infectious material in the front part of the eye, the aqueous humor. So we can draw some of the fluid out using a little needle on a syringe. We draw some of that fluid out, and we put that on slides. And here you can see a slide showing a lot of those similar bacteria, same bacteria that we saw actually earlier. So small round bacteria, they cluster like grapes. So this is Staph aureus. So again, the same bacteria on the eyelids. And so these infections that we see after cataract surgery come from the eyelids, come from the skin. So it's important to do a good prep to disinfect the eye So we use iodine most commonly to disinfect the eyelid, eyelid margins, the eyelashes, the surface of the eye, and we take special precautions like draping the eyelids and making sure we wrap around the eyelashes, making sure that when we do our surgery that we have good sterile technique after surgery. We want to keep everything clean. We want to make sure those incisions at the time of surgery seal well so that you don't get infections like this. So treatment for this, injection with antibiotics, or depending on the organism, it may be something other than bacteria. So fungus, we may do antifungal injection. So that a schematic photo on the top left is just showing how injections are administered into the eye, into the vitreous cavity. And that will spread, circulate within the eye and go into the aqueous as well. And here on the bottom left, you can see an actual administration of that injection. Sometimes surgery is required depending on the severity of the presentation of infection. And here you have these small instruments that remove that gel. So there's vitreous gel, so that's removed first. That also removes some of the microorganisms. And then medication is injected into that vitreous cavity at the time of surgery as well. And on the bottom right, you can see you're looking at the retina. So that's that orange tissue that's seen in the background. That yellowish circle is the optic nerve, and those vessels are coming, those red fine lines or vessels coming off the nerve. And then this medication has been injected into the vitreous cavity, and that's being removed with this instrument that functions like a cutter. It cuts the gel into small pieces and then vacuums it out. So now I'd like to turn it over to our microbiologist, Regis Kowalski, for his perspective.
Yes, hello, this is Regis Kowalski here. I want to talk about ocular pathogens and opportunistic normal flora of the infections that Alex described. I also, these are all my friends at the Campbell Laboratory that I work very closely. As you see in the red there, we have a website. You can visit that website at any time. It has all the information that a lot of that Alex is describing, and what I'm describing now. All you basically have to do is to go eye microbiology, and it'll get to you. So the Campbell Ambition, it's diagnostic with the definitive and timely detection of an infectious disease of the eye for patient care. We explore and validate new practical tests for detecting ocular pathogens. We have a research laboratory. We investigate new antimicrobial agents, which is anti-infectives, antivirals, antiseptics, and biocides. We also monitor ocular infections and anti-infective susceptibilities, as Alex shown. Today, I'll just sort of talk about the monitoring ocular infections. Monitoring ocular infections. The data may be a function of what I'll be showing of culturing bias with three apparent scenarios. Why do people go to get cultures? There are people who have infections and do not seek help for many reasons. There are those people who have infections and physicians empirically treat based on their training intuitive. An elderly doctor might treat you much different than a younger doctor from experience. And there are those people who have serious eye infections that require laboratory studies and treatment, and that's where we come in. Monitoring provides important laboratory data of ocular infections for improved patient care. So our objective, we always want to determine the prevalence of the causative agents of ocular infections that include bacteria, viruses, fungi, and protozoa. The first slide, that's what we're looking for bacteria. The second slide, this is what virus looks in culture. The third slide is showing fungus, actually in the cornea. The fourth picture is acanth amoeba growing on a plate. These are actual amoebas that grow on top of a plate. And the last picture is some microsporidia from a person's cornea. The majority of infections from our laboratory, although there are a lot of things can be infected, these are from patients with infectious keratitis, endophthalmitis, and conjunctivitis. The first slide is endophthalmitis. The second slide is a keratitis. And the third slide is an adenovirus EKC patient. You can see the redness. So let's talk about each of these. Who are the players in conjunctivitis? The prevalence of laboratory positive detection from conjunctivitis probably represents those patients with serious conjunctivitis that were deemed necessary to culture. Many times, in general, conjunctivitis is not cultured because it's not that serious. But when it is very serious, you want to get it cultured. So in the players, you see a pie chart on the side. You can see that most infections we see are from adenovirus. There's probably a lot more because a lot of times they're not cultured. We have a lot of different bacterial infections. And as you can see, we have coagulase negative staph. And this is generally considered normal flora, which I will go before, but sometimes there's so much staph, coagulase negative staph, that we do consider it as a pathogen. The Staph aureus is the #1 bacterial pathogen. And you see we talked about children with pink eye, we're talking strep pneumoniae and Haemophilus. We also have chlamydia on the bottom. So there's a lot of different things that can cause conjunctivitis. When it comes to keratitis, the culturing of presumed bacterial keratitis is dictated by the size of ulceration, clinical presentation, physician training, and ready access to culture media and microbiology laboratory. The prevalence of laboratory positive detection for keratitis may be a little bit better sampling because if a person gets a corneal ulcer, they're going for help. They're going to their ophthalmologist, so they will be cultured. But the prevalence of HSV infection is probably underestimated because generally HSV infection is not cultured. So the pie chart on the right there, you can see there's a lot of different things that cause infectious keratitis. You see HSV, which is showing the most. We get acanthamoeba, amoeba, which is an amoeba that actually attacks the eye. You might have seen that on TV as far as very serious infections. And then there's fungi, which is the mold and the yeast. As far as bacteria is concerned, Staph aureus is the #1 bacterial pathogen, but we've always heard about Pseudomembranes aeruginosa. And this is generally due to the contact lens infection. As once again, you see at the top there, coagulase negative staph. These are considered normal flora in our eye, but if there's enough there, we consider it a possible pathogen. The third thing we want to talk about is endophthalmitis. The prevalence of laboratory positive detection from endophthalmitis may represent a closer sampling of the general finding from the total endophthalmitis population set. That's because when you get an infection side eye, it's very serious. You have to go to an ophthalmologist and find out how to treat it. You want to get better. And these are generally due from cataract extraction. And so after you have cataract extraction, once again, as you're going to see the pie chart on the side, is caused by normal flora. But this time it's like 54% of the time is by coagulase negative staph. And most endophthalmitis are caused by as we call gram-positive organisms like staph and strep. Gram-negatives don't cause too much of endophthalmitis. Our pie chart on the side did not have a complete data set to accurately show our fungal incidence, but we did have a fair amount of from 2015 to 2018 of fungal infection. And some of these are what they call endogenous endophthalmitis. Endophthalmitis can be like, if it's endogenous, that means it comes to our systemically. It's not due to surgery or from an injury, trauma. So all these pie chart that I just showed you, there's a citation for it. These are the things we like to do and really look at the prevalence. And this is a publication that we've done based on those pie charts. Now talking about opportunistic flora, one of the things we always want to do, when does normal flora cause problems? And three of the pathogens that really cause problems. One is coagulates negative staph, and we wanted to figure out which. There's like 52 different species of staph, and we wanted to find out which was the most prevalent. And we found it was Staph epidermidis. We found out of all. We took 50 isolates. We found that 90% was some Staph epidermidis. We took 50 isolates from keratitis. We found that 86% was Staph epidermidis, and the conjunctivitis was less. It was only 68% due to that Staph epidermidis, which shows us that this is the most frequent pathogen, but there are other species of staph that can cause problems. The next isolate we did some research because they're very difficult to identify bacteria sometimes. The next one was Moraxella. The Moraxella, we found that there was two major isolates that caused problems in the eye. Moraxella is a bacteria that really affects the eye more than other parts of the body. There is a few species that attack the eye, which was Moraxella cataralis, but the eye has certain ones. So once again, they're very hard to speciate, and with UPMC Microbiology Laboratory, use a multi-TOF mass spec, which was a very good technique we like to get in our own laboratory one day. We were able to definitively identify these two isolates. The other isolate we want to talk about is diphthroids. Just about everyone has diphthroids in their eyes, and that's why we call it an opportunistic flora. These are gram-positive pleomorphic rods, generally Corynebacteria, Cutibacteria, and they're described as Chinese letter right because they're very pleomorphic. They're club-shaped. When you look home on a slide, like I said, they look like Chinese letter writing, but they're very difficult to speciate. There's no consistent method. I've tried, and this is the future. They are very frequent inhabitants of the normal inflamed eye, as I indicated before, and just about everyone has it, whether they're normal inflamed, but we don't know whether they're pathogens or not. We can select the slide to the right. It's a corneal scraping. It's filled with diphthroids, but we're not sure whether this is a pathogen. Could it be a cellular saprophyte? So maybe it has something to do with the immunogenic properties of the eye trying to fight off another infection. And in our department, we have Tony St. Ledger. He's doing a lot of research in this area, looking at diphthroids and whether it's immunologic properties in helping out the eye. So the future of our laboratory at the Charles T. Campbell Laboratory will include, we're always looking for better validated methods to detect ocular pathogens. We always want to improve approaches to treat infectious ocular disease. There's different methods of, generally we treat topically, but there may be other mechanisms of applying antibiotics to the eye, which others in the department is looking at. And we're always looking for cutting edge methods to definitively identify micropathogens. And I think that's where we're going to be going in the future. And with that, I thank you. We have a lot of friends out there who help us out. We work with CORE, we work with the university, the Lions Club, Research to Prevent Blindness, the Eye and Ear Foundation. Of course, we have the Pirates and Penguins and the Steelers, all the thanks. So I thank you, and we can start with the questions.
Great, thank you. Thank you both presenters. You know, this is a wonderful topic. I can see we already have some questions, but I'm going to start by asking a few things because, you know, Dr. Mammen, you mentioned in the beginning how the Charles T. Campbell Lab is something that's kind of unique across the country in terms of the fact that we have a pathology lab specifically for eyes and the infections that we get in our eyes. Why is that the case, and what does it mean for this region that this is so unique?
Yeah, I mean, as to why it's the case that we still have a lab, it's due to great leadership, you know, both institutionally and leaders like Reg, who's been here for 45 years now, who really, you know, spearheaded the efforts to stay relevant, you know, and our missions are not just for clinical practice, but to teach and we do a lot of that, not just internally, but internationally, and to do research. And Reach has done quite a bit over the years, and we've been fortunate to be able to work with him and in these last few years. So staying relevant, being able to contribute, and having great support, from people like the Campbell family, have made it possible to continue to thrive, really, and not just survive, but really thrive as a specialty laboratory. And thankfully, as we are looking to move into our vision and rehabilitation tower at Mercy next year, we have continued support to have a ophthalmic microbiology laboratory there and continue the tradition of providing great microbiology care and good eye care to the community.
Well, you can certainly see it's important, and as I understand, we get specimens from really all over this region and beyond, right? In terms of being able to evaluate, so we're providing, obviously a lot of good research, but also a lot of very good, important care and understanding what may be going on in someone's eye.
Absolutely.
So we have some questions. I'll get to those, and this is the time, folks, for our audience. We still have a lot of folks on here. This is a time for you to be able to ask questions yourself. So all you do is to go to the Q&A function at the bottom, click on it, and then just type your question. So we'll start with the ones we have. What can we do in our everyday lives to avoid these eye infections?
So if I can share my screen, I just put together a little list while I was, let's see if I can share that. So yeah, as severe as these infections can be, as we just demonstrated, avoidance is key, right? An ounce of prevention really goes a long way. And on certain times, you can't avoid it, but when possible, it goes back to those basics of good hygiene measures. And, we all touch our eyes more than we know, touch our faces more than we know. And so it's very easy to spread infection. And the most common example is when we're talking about conjunctivitis or pink eye, viral conjunctivitis being the most common. And the virus, the adenovirus that causes the common cold, it lingers on surfaces for a week. So, you may not be necessarily around someone who has a cold or has pink eye, but they've been in that area. They may have touched their eye, they may have touched the surface, and then you touch it, and unknowingly, you are picking up that virus and spreading it to your eye. So washing and sanitizing hands often, avoiding touching eyes, especially if you haven't washed your hands. Practicing good contact lens hygiene, including not sleeping in contact lenses despite advice that you may have gotten even from some optometrists who may say that it's okay to sleep in contact lenses. We have had patients who've been sleeping in contact lenses, say 25, 30 years, they haven't had a problem, but then, that one time that they're sleeping in the contact lenses, a combination of factors, they may have touched their eye and touched something else, or for whatever reason, they may have had an abrasion on the cornea from the contact lenses. They get a bad infection. And so all it takes is that one instance. And these infections can be debilitating, can really change our lives. So practicing good contact lens hygiene. If you've had eye surgery, taking care, to avoid the dust, the water in the eyes, and avoiding contaminating the drops. Wearing good eye protection, depending on what you're doing. Just a few of the things that I wanted to touch on, ways to, avoid some of these severe infections.
Thank you. That's very helpful. You kind of stunned me there with the adenovirus can live on a surface for up to a week.
Yes.
Actually,
Wow.
it's 7 weeks. We didn't go any further.
Wow. Okay. That just makes you want to go and clean all your surfaces. So here's the next question. What are some of the exciting, surprising discoveries in your research in the past year?
Reid, you want to take that?
Well, we've worked with the eye bank, for instance. The eye bank has been trying to find a way to disinfect corneal tissue from fungi. Fungi in certain parts of the country. Fortunately, not in Pittsburgh, but some people have a problem of having contaminated corneal tissue being transplanted and causing a post keratoplasty infection. So we've been working with trying to figure the better ways of disinfecting the corneal tissue early on, so that it doesn't get passed on to the patient. We've been looking at also at antiseptics to maybe prior to intravitreal injections. We've been comparing different types to make sure that, because a lot of times these injections, they put it in, povidone might be a little more stinging the patients, whatever. So we're looking for something that maybe it might be less stinging to the patient prior to the injection. Yeah, we're always up in our other laboratory. Eric Romanowski's looking for new ways of trying to for adenovirus. There is no treatment for adenovirus infection whatsoever, and so we're still trying to find that out. And we're working with pharmaceutical companies actually trying to find a new treatment. And we're always working with some type of with a pharmaceutical company looking for new drugs for treating eye infections.
You know, I think people need to remember, those who, on that the eye is one of the entry points for infections to get into our body. Obviously, those precautions that you gave, Dr. Mammen, I think are really important for people to keep in mind, and also making sure if you have any symptoms, right, that, report it to your physician right away, because they can cause some damage to your eyes long term, and that's what I took away from today's message. So, all right. So, what would you like to see accomplished in research? Oh, we're getting lots of questions here now. What are some things you'd like to see in your research, or be in the future, I guess, to be researched?
Well, I think we're still trying to find a better way to treat adenovirus infections. We also have tried to find a better way for acanthamoeba. These are acanthamoeba. You probably saw that on TV, the people going blind. It gets into the cornea and causes a lot of damage. So I think we're.
Is that common, Reid? Is that acanthamoeba? Is that on on most surfaces or places, or is that pretty unusual?
No, it's in our water. It's in the water. It's in the ground. It's all over the place. It's just a matter that for some reason that it actually started with contact lens cases. I think education is really cut back on. That was probably the number one way of having a decline. That people used to make their own contact lens solutions. I'm not sure if they still do that, but if you make yours, it's a hardy organism. So if it gets into your contact solution, then you can get to your eye. In some parts of the world, it's really bad. Like in England, they have cisterns on top of their houses, and they're filled with acanthamoeba, and then they'll get the infections. So those are just two that we're really trying to maybe cut back on, and I think, and keep on surveillance of pathogens and making sure there's no antibiotic resistance.
So there's one other thing I would add. Sorry to cut you off,
go ahead,
Lonnie, but sometimes despite our cultures, despite our smears, there are times when we cannot diagnose what we're dealing with. And so there are newer molecular diagnostic technology that are available, like polymerase chain reaction, that haven't been validated yet in microbiology and ophthalmic microbiology. So that's going to be the next frontier. And so, we're hoping to evaluate that further and incorporate that really into our practice going forward. So testing for like fungus, there may be times when it's a fungal infection, but despite our cultures, nothing grows, and having other ways that we can detect what the microorganism is really is something that we are eager to look into.
So when someone has an infection, I guess this question kind of, I imagine, depends on the type of infection, but how long does it take for patients to recover once some of these, for some of these treatments for common eye infections?
So yeah, I mean, like you said, a lot of it depends on what type of infection it is and how severe, because even a common infection like a conjunctivitis, a viral conjunctivitis, can manifest in different ways. But say you're run-of-the-mill conjunctivitis, usually within a week. Patients are seeing improvement. And so, when we don't see that improvement in a week, then we start looking at more than, say, supportive treatment for these patients so that we can get patients back to their daily lives. And that can involve things like using steroid eye drops, which we typically don't use in your usual conjunctivitis, just because even though it may make the eye look better, feel better, the virus continues to be there and it continues to be spread. But in those individuals that need a quicker rehabilitation, we may use steroid eye drops, for example. Other eye infections, depending on the severity of it. So sometimes it's just a small corneal ulcer in the periphery of the cornea that responds quite well. So within a week, they're feeling a lot better, they're seeing better again. The more severe ones can take weeks to months. So it all depends on the presentation, how severe it is, and what the bug that we're dealing with, what the microorganism that we're dealing with. Some are harder to eradicate than others. Bacteria in general can be easier to treat than, say, Acanthamoeba, as Regis was talking about, or fungus, which is harder to clear from the eye. But again, it depends on what the bacteria is and how severe the initial presentation is, whether the patient has other systemic conditions, they may be immunosuppressed. So for whatever the reason is, it may be more prolonged than your usual presentation.
Thank you. So I think we got people thinking, because you're talking about viruses, people are asking about COVID. So talk about COVID and eye infections, and have we done any research on COVID in the eyes?
So there's certainly a lot of research that's been done on COVID and the eyes. And we have not done any research here at University of Pittsburgh and with our Campbell Laboratory. What we can say about COVID is it's not that common to have ocular manifestations with COVID. It usually is certainly not a presenting. So it's not one of those situations where, a patient has a red eye and then we diagnose it as COVID. Usually they're going to have other manifestations of COVID. The upper respiratory symptoms are going to precede the COVID, and the ocular manifestations tend to be more like a mild case of like a viral conjunctivitis. But that usually follows the other presentation. So COVID has been also recovered in patients, from inside the eye. So our eye bank, for example, when we obtain tissue from our eye bank, our patients are screened. The donor tissue is screened for COVID. And so COVID's been recovered from inside the fluid in the eye.
Wow.
Even in asymptomatic patients. So that's something that we certainly look for when we're using tissue. But as far as, whether to worry about COVID in the eye, I would say less of a concern than the respiratory manifestations of COVID.
Understood. So are people with dry eye more likely to get eye infections?
Yeah, absolutely. Just like the skin, if the surface of the eye dries out, it's more likely to crack, to break down. So when that surface, it's like a barrier, right? Just like the skin is a barrier for the body, on the surface of the eye has its own layer of skin. So the cornea has an epithelium. So if that barrier that keeps the microorganisms out gets compromised, then you are more likely to get an infection. Contact lens wear can also cause compromise of the surface, can cause small abrasions that can lead to corneal infections and ulcers. So certainly dry eye plays a major role, and keeping the eyes well lubricated not only helps the eyes feel better, see better, but it can also prevent infection.
I meant that. Thank you. That's great advice and great question. So, um, infections on the retina, are those common, and is there anything new related to how we can, treat infections in the retina?
So infections of the retina, relatively speaking, not as common as say a conjunctivitis or a corneal infection, but certainly can be seen either from spread from say another infection in another part of the eye, or an endophthalmitis like we showed. It can also involve the retina. It can also come from the blood. So through the blood vessels, through the bloodstream, you can get an infection that way as well. So depending on, again, the type of organism that you're dealing with and how severe that infection is, surgery sometimes may or may not be successful. The retina has less resilience than say the cornea. So if you get an infection of the retina, it's a very thin tissue. It's kind of like, if you think of it like the film in a camera. So once that film gets damaged, you can't just put new film into this camera, unfortunately. As far as, so it depends on what part of the retina is involved, but it can certainly, once you get an infection that involves the retina, can certainly compromise vision quickly and can be permanent. So in a cornea, you can do a corneal transplant, you can put a new cornea on there, but unfortunately not so with the retina. As far as research in this area, yeah, I mean, certainly it's been looked at, but when we're talking about the retina, it has a lot more cells and then nerves. So it's a nervous tissue, so part of the nervous system. So it senses all that light. So it's a much more complex tissues than say the cornea. So to do a transplant of that involves a lot more than just removing tissue from one eye and putting it in another. So far, that there hasn't been much success in that type of treatment, but certainly there is, research. The biggest thing is how do we avoid getting to that stage? That's going to be the biggest likelihood of success. Once it's been damaged, trying to replace it or fix it is a lot more challenging, but certainly, research is being done worldwide. We currently here are not looking at retinal infections as a research focus, more on retinal degenerations, more genetic conditions, and macular degeneration, for example, is more of a focus than infections.
If I could just interject this. Most of the infections that attack the retina are virus, and we've had great success in detecting these virus in our laboratory. Our retinal service is very good at it, and like I said, they're mostly virus. They take a tap, we send it for PCR testing. So fortunately, although it's not fortunate to get a viral infection of the retina, but if it does occur, we're pretty good at finding what the cause is.
That's good to know. And as Dr. Mammen said, unfortunately, that when retina tissue is damaged, that's sort of the holy grail of a lot of our research is about, is trying to find ways to help people who've had, whether it's from degeneration, or I guess, or trauma or injury, ways to restore that vision. We do have a lot of people working on it in that respect, with everything that's doing in more regenerative medicine type of work for vision, which you can tune into some of our other webinars. We'll have certainly a lot of those on that type of research. So that's the end of our questions, but I'm really excited that we did this with you guys today, because again, this is something that I think all of us who hasn't had, oh, we got another one. I'll read that, but who hasn't had, my kids are older, so these days are over now, but I remember getting, coming, oh boy, now they're coming in like crazy, but getting, pink eye. That's what you refer to conjunctivitis. We think of as pink eye. Boy, it's miserable, and you want to get taken care of. And obviously, as we just saw, it can be very damaging. So you definitely want to get these things addressed and taken care of. So here's one about Pseudomonas. How about Pseudomonas infections and contact lenses?
So certainly, yeah, most common infection that we see with contact lens wear. There are different strains of Pseudomonas. Some are more virulent than others, but you can get Pseudomonas infections apart from contact lens wear, and we certainly see that as well. But certainly with contact lenses, it goes back to proper care. So contact lenses, if cared for properly, are a great resource. It can really change lives, but it can also change lives the other way. If not properly cared for, can really lead to visual compromise and even globe eyeball compromise. So we were doing research as part of the Campbell lab, looking at Pseudomonas infections and trying to better understand them and how to better manage them, because these infections, as I had mentioned, they progress really quickly and leave a lot of damage behind. So we're looking at ways, one, to treat them better. Although we have good treatment options, it's just sometimes it's such a severe infection that it would be useful to find ways to prevent it from causing as much damage. And then if it does cause much damage in the way of scarring, how to deal with that without having to do a corneal transplant, which is really the main way that we handle corneal scars now, in addition to contact lenses, rigid contact lenses.
Okay, well, it looks like we're ending not with a question, but a comment. And it says, thank you for the informative presentation. It's wonderful that you provide these webinars. Well, you're very welcome. And thank you to our presenters today. Thank you to all the guests who came on today. We enjoy doing these programs, but I think what I've realized as we've done this now for 2 years, believe it or not, that we've been doing these programs, is that there seems to be a thirst for knowledge on the topics that we're presenting. So we'll keep doing it, because essentially that's also relates to what we're trying to do through the foundation, is to help people understand what the problems are and how we're trying to solve those problems by what we do in research and other areas that we work on at the institutions. So thank you. Last little comment, maybe we have 3 minutes. As an ophthalmologist, I notice you wear glasses, not contact lenses. Is that caution from the ophthalmologist? I'm wearing reading glasses, which is to read your screen here, but Dr. Mammen and you, Reed, probably have to answer for that occasionally, right?
It's strange that I found for many years that ophthalmologists do not wear contact lenses. I've seen that for years. Now, myself as a microbiologist, if I wear contact lenses and I would get an eye infection, I probably would never live it down. So that's why I don't wear it. But there's that is a thing that I've noticed, that they just don't wear contact lenses. I don't know why.
Yeah, and so certainly with contact lenses, it's and in the field that we work in, when used appropriately, it can be great, right? So it can be useful when we're doing surgery. If we're exposed to fluids, not as great an option. On the other side, and this may be where what we're getting to with this question, whether refractive surgery, so refractive surgery, I often get that question, why are you still wearing glasses? And so part of the refractive surgery process is an evaluation, and we see, is this patient a good candidate? So part of that is it safe to do this surgery in this individual? And does the patient have a good understanding, of what the compromises is? Because even with refractive surgery, you're making some compromises. Not everyone is a great candidate. And for me, wearing glasses, I like the extra protection. I've gotten used to it. I don't mind how I look with glasses. So multiple factors, the amount of correction that would be needed. So I used to wear contact lenses, and I developed an intolerance to them. That's the main reason I don't wear contacts anymore, and I wear my glasses. And at this point, I've gotten used to it. The window for refractive surgery between early 20s, late teens, and really late 40s, maybe early 50s. So that window is also narrowing for me. So, but bottom line is it doesn't bother me. I like the extra protection, but just like anything else, just like contact lenses, refractive surgery in the right patient is a great option. You know, it'd be unethical for me to do something that I don't believe in. So just because I wear the glasses doesn't mean that, you know, I don't believe in, say, the refractive surgery in the right individual. And as long as we do the proper education and you understand, you know, what is involved in getting the surgery, it's a great option.
Okay, we are at the end of the hour, and we do, I do see some more questions here. So what we do, in this case, we'll send the answers to you via email. So thank you for everybody again, and gentlemen, thank you for your presentations today.
You're welcome.
Folks, we will look forward to having a good Friday and bring you another program in 2 weeks. And again, for those last few questions, we will get you an answer via email in short order. Thank you so much.